hello to everyone. My name is Geoffrey Khira, and I'm joining you guys all the way from Nairobi, Kenya. And I'll be just giving a brief presentation on lessons of the case study based on with the work that we do as Basic Needs, Basic Rights Kenya. So basically, as an organization, we are actually based in Nairobi, and we have programs that we implement in the communities that are geared towards improving matters mental health in the communities that we work with. As you can see, we as an organization have been in the space working specifically targeting youth in the communities that we work with, and we sort of work closely with the government and also the regional state actors in the space of improving access to quality mental health services, basically empowering communities to be able to provide care and social support in matters pertaining to mental health service delivery. Our annual reach is over 1.2 million youth across Kenya towards this target area that I just mentioned. So with regards to neurodivergent care in the country, 55% of children currently in our schools have some form of disability. Largely, if I can mention this, those that are prevalent, especially in our programming, we have matters communication, cognitive, self-care, mobility disabilities, and 11% of learners in Kenya usually have a form of disability. And the statistics further goes to show that in terms of the teachers who are the custodians of education in our schools, 78.3 of teachers that are actually in the special needs education have no training of whatsoever in terms of just promoting inclusion to quality education in the schools. This exclusion, of course, has a very great impact in terms of access to quality education for learners who have different forms of disability, and especially in terms of neurodevelopment disorders, where we have ADHD and intellectual disability being very high, followed by autism. Now, I'll just be sharing case studies in regards to two counties that we are intervening in as Basic Needs, Basic Rights Kenya. This is Kilifi and Bungoma. Kilifi is a county that is located in the coastal region of the country, and Bungoma is also a county that is located in the far western side of the country, neighboring Uganda. So what we've been doing in these two counties with regards to just improving the quality of care in neurodivergent conditions is we work closely with the caregivers, the caregivers of learners who have these disorders. We've been able to actually capacity build them on matters mental health and first aid, the Quality Rights Initiative, and basic skills that actually they can use in terms of just improving the quality of care of their respective loved ones or children. Then we've also trained teachers and head teachers on special needs education, how they're able to refer cases that come up in the schools, and how they're able to also respectively accord the right care that will not hamper the quality of education that learners with the neurodivergent conditions are actually prone to. I think the previous presenters have just sort of alluded to these challenges that usually in terms of, I think the presentation that you shared, Naomi, having the teachers understand from a point of, how are they able to also provide an environment that is actually inclusive for learners with these conditions to be able to equally participate. So our trainings in this with these teachers are usually largely in that perspective, also cognizant of the types of disorders that are coming up in the schools that we work in. Once that has been done, we've also trained now the parents and the caregivers to be able to actually form support groups. These support groups sort of have the parents have one common goal, understanding, especially in the communities we work with. If you can just give a brief case scenario, you find that a school is located around 30 to 40 kilometers away from where the parents are staying. So accessibility provides a key challenge. So the parents usually, with the support groups, have been able to work together to be able to accord roles so that they're each participating in ensuring that the learners are actually accorded the right quality education in the schools that are in the communities. And then, of course, lastly, the learners with disabilities also have been very deliberately empowered and included to be able to actually participate in the other extracurricular activities in the schools, to be involved, in what the general school is participating in. A context here is in our learning system, we have integrated schools where we have a classroom that is given for learners who have disabilities. So most of the times we find that this unit is sort of forgotten in what the larger school is participating or doing activities. So we've been able to train the teachers in those schools in how they're able to also offer special needs education, how they're able to also deliberately incorporate learners from these units to be part of the larger school initiatives. And this has actually seen learners in these schools being included in national events, which I think is a very big win even for us in terms of promotion of inclusion in the education space. And then lastly, the parents in these schools, we've been able to have them become peer advocates in terms of raising awareness in the communities that they live in. So they're able to also reduce the stigma associated, especially it's a key thing we are seeing in the communities we're serving, where parents don't see the need to actually take learners with their respective disabilities to access quality education, because of misinformation, despair, and also cultural beliefs that are usually stem from having learners with disabilities. So we've been able to have these parents conduct very multiple community forums to be able to actually advocate for inclusion of their respective children in the communities. So of course, this is the objective of this specific case study, of course, was to explore how this peer support and family engagement that I've just mentioned has been able to enhance the therapeutic outcomes. Therapeutic outcomes here involves when we have the occupational therapists and the physiotherapists go to the respective homes and offer the respective therapeutic interventions. What's the outcome of having the peer support and family engagement in that? On the same regard, also, what is the educational inclusion in the schools that we work in or the schools that we intervene? Is training the teachers, does it have an impact, raising awareness in terms of how the teachers are able to actually accord the right environment for learners with the neurodivergent conditions to be able to partake equally as learners without these disorders? And then lastly, in terms of the psychosocial well-being of neurodivergent learners in low resource settings, what is the impact of having these peer support and family engagement interventions? So our findings, of course, this has been a review of the reports we have in the groups that I've just mentioned. These are groups, we have a huge pool of parents, caregiver groups, but we just were able to actually analyze longitudinally the data that we have from the groups that have been part of our programs from 2023 to 2025. And the quality interviews actually involved quality interviews and FGDs was with regards to the caregivers, the parent trainers that we've involved, the teachers, and observations of 4 special units that are in Kilifi. And issuing caregivers survey tracking the well-being, stigma, and inclusion of 9 groups, 5 in Bungoma and 4 in Kilifi. What came out is with regards to the caregiver empowerment, we were able to actually it was evident that the peer learning meetings that we were able to conduct in the period of this specific analysis, that the peer learning meetings provided safe spaces for the parents. This is mainly women caregivers. A key dynamic we are seeing in the groups that we work with, the caregivers or the ones who usually attend these peer support groups are largely women, because we've seen actually in the communities that we work in, there are cases where the male parents have been able to abscond from their duties because of the cultural perceptions that come with having children who have neurodivergent conditions. We've had cases where the women, because they're left to be in the homesteads during the day, they're the ones who are actually free to participate in these psychoeducations and follow-up care of their respective children in the health centers. So that's why we have almost 95% of our group therapy participants being women. And the outcomes that we've seen from the caregiver empowerment is, of course, there's increased caregiver confidence and skills. The parents have been able to be very focal in terms of championing for inclusion of their children, especially in the education and community. They've been actually at the forefront in terms of reducing stigma, and we have some very good success stories of the caregivers going and bringing back their partners to be part of these deliberations, because of course the wins that are coming out cannot be achieved if we have a discord in terms of understanding of the cases at hand. And then, of course, formation of parent support self-help groups has also been has come out as a key result, where the parents have been able to now cascade the same in their respective distant peers who have actually undergoing the same sort of challenges. And then lastly, stronger school family linkages. And this is largely because now with the teachers also capacity built on how they're able to improve inclusion in their schools, there's been that strong connection between the two. With regards to rights-based advocacy, we're able to see a greater teacher responsiveness. This is largely stemming from the understanding of the cases that they're actually currently responding to. There's also been increased community awareness on neurodivergence and inclusion. This is largely when the parents' peer support groups conduct the community forums where they go to the communities and raise awareness with regards to the various conditions. We've seen parents come out and actually be open to be part of these groups and be supported to actually offer the right standard of care improvised by the available resources so that their children are also able to be able to access education. And then lastly, families have been empowered to advocate for rights in schools and local systems. This has been really a big win because now local leadership is able to respond to these cases as they emerge. Of course, challenges that we've seen, just to mention three. One is, of course, resource limitation for sustaining the caregiver groups. These groups I've mentioned, they are in the marginalized bit of the country where we have very inadequate resources allocated. Access to schools, access to health centers is a big concern. So of course, there is that bit of resource limitation to sustain these groups' initiatives. Shortage of essential medication. This is really key, especially in areas where we have learners who have epilepsy. Epilepsy is amongst the key top prevailing condition that we're seeing also in the learners in these schools. It's comorbid with the other neurodivergent conditions that I've just highlighted. And then lastly, dependence on external facilitation for group continuity. This has been also a big challenge because most of the communities that we work with, the poverty index is quite severe. We have people who, the communities that we work with live on less than $1 a day. So you can imagine when we have them to be participating in these groups, they require some sort of means to actually go to those group discussions, group interventions. They require support to actually go to the schools. So that's a key challenge that we are seeing in the communities that we serve in both counties. And then lastly, just to wind up my presentation, is conclusion that we are seeing, especially upon this analysis, is that peer-led, family-engaged, rights-based models actually strengthen caregiver resilience. In as much as, notwithstanding all these other challenges we're seeing in these groups, the fact that they are peer-led, installs a bit of ownership. Installing these skills to these caregivers has been very instrumental in terms of just also giving them hope that they're able to actually support their children. The smile that usually comes from the parents when we do the ND assessment and giving us feedback that now they know how to better respond to their children who have the neurodivergent care conditions, we do take that as a big win and a big outcome, because at the end of it all, in terms of having these caregivers improvise the resources they have at hand to actually improve the quality of living, that stands as a big win in the communities that we work with. Another key thing is, of course, improved learner inclusion in education reduces stigma, and this has been evident in the schools that we've worked with. In fact, we've seen enrollment increase in those schools now that the head teachers and the teachers are understanding how to better promote inclusion in their schools. Special needs education is not just about having an integrated unit. It's about having the resources and having the right mindset in the school that enables learners with the neurodivergent conditions to be able to participate equally as the learners without these disabilities. And then lastly, scaling pathways should involve partnership with ministries, schools, and community health systems. Hereby, or on this point, we work with the Ministry of Education, the Ministry of Health, to be able to establish a clear referral pathway from the teachers who are in the schools to be able to identify these cases and refer them to the health centers. And I think this has been really a big win in terms of promoting that holistic mode of approach in eliminating the barriers that learners with the neurodivergent conditions usually are faced with, especially in the low resource settings. And the picture there that you're seeing, this is just one of the groups of caregivers that we've been able to capacity build to work closely with the community health systems, so that they're able to also strengthen the referral system in the event that there is need for care for their learners who have the neurodivergent conditions. And another key thing that we usually do with these groups, we also train them, capacity build them on livelihoods aspect, so that we're able to break that barrier, the cycle of poverty and mental illness, because we do believe that once we've capacity built them or economically empowered these groups, they're able to fend for themselves to actually afford the medication needed and improve their quality of life on their day-to-day. That sums up my presentation. Naomi, thank you so much.